breast cancer treatment. I am assuming the vast majority of you will not probably work in a treating breast cancer office. But you kind of need to know what where the basis of what we got was. So need to understand about breast cancer things more relevant to primary care. So I'm going to, usually on an annual basis, I speak at a primary care meeting here offered by Family Practice OU. And I thought I would, you're not expected to know everything on these slides or anything, but I thought I'd take you through that and sort of stress the sort of lessons that could be gained if you're working in a primary care office. And what are the hot controversial issues? What's going to change? Things move. Things move quickly in breast because we have lots of research data. So what we think today may not be what we think 3 years from now. So by the time you're in an office actually doing this, it's likely all to be different. We've talked about the basis of how we got to where we are currently and what the treatments look like now. And you know about mammographic screening, but mammographic screening is a hot controversial issue. Why is it so hot? Why is this going to change numerous times in the next decade, decade and a half? So I thought we'd flip through those issues. So, talk about new improvements. We've had a dramatic decrease in the deaths from breast cancer nationwide, and we're beginning to have a substantial impact. About 35 to 40% of all cancer survivors are breast cancer survivors. So it's likely if you're in a primary care office, you're going to see a fair number of women who've had lots of this stuff done to them, who share all the battered and damaged things that we've done. Burn, scorch, slash, cancer treatment stuff. And we'll deal with the side effects of that for a lifetime. There are huge screening controversies, so let's kind of flip through some of this. The first thing about breast cancer is, as opposed to any other sort of organ system practice, breast cancer, through an unusual sequence of events, developed an annual meeting where the vast majority of clinical researchers in breast cancer meet on every year for a week. And for some odd, quirky historical reasons, it's in San Antonio. But it's been going on for about 40 years. And out of that came an effort to combine the world's research data in breast. That was all the clinical trials for breast cancer, multi-center clinical trials for breast cancer have given their crude data to the Oxford meta-analysis group to determine what are things we can learn from the compiled data of all the clinical trials. And they have every trial since 1955 to present with the exception of one are in that data set. And they the statisticians recrunch the data, and as a part of that week-long event, they have an hour every year with an auditorium of over 10,000 people where you can hear a pin drop for that hour, because they're going to tell us something about breast cancer and the biology of breast cancer that none of us knew by looking at the compiled clinical research data set from the whole world. So it's an impressive meeting. The NCCN guidelines developed in the United States to standardize care at first comprehensive cancer centers and now have become the standard of care since about 2000 forward anywhere in the US. And as a result of a consensus in 2000 at San Antonio, every clinical trial worldwide, the standard arm is the current NCCN guideline, the experimental arm is compared to it, so you can compare clinical research data from any trial in the world. It has the same standards, the same outcome measures, everything's exactly the same. Because of that, we've made pretty rapid progress in breast cancer. So we're learning that 10-year survival is much better for early stage breast cancer for breast conservation than mastectomy. First seen by the Dutch, now it's been repeated by 23 other countries. So we're consistently seeing that. Remember what I said about breast conservation, it's actually treating a bigger area than you treat with mastectomy. So we're going to hear more of that over time. Breast conservation patients are more likely to have NCCN guideline compliant care because you involve more specialties. Surgery, medical oncology, radiation oncology. The more specialties involved, the more likely nobody misses a baton pass. This is a relay race. If we drop the baton between the specialty towers, things deteriorate quickly. So detail, attention to detail, dotting I's, crossing T's, never deviating, is a huge portion of oncology care and best demonstrated in breast. Recurrence patterns now are such that the majority of patients with breast cancer will live 5 years, and they won't recur until they're between 15 and 20 years out. So because we're changing recurrence patterns, that means oftentimes they may be back in the primary care's office and not gone to see an oncologist for years. So it's going to have an increasing impact following cancer survivors and keeping track of that when you're working in a primary care office. Prevention of secondary malignancy has a profound effect. There's a trial that's being reported today at the American Society of Clinical Oncology meeting in Chicago, Canada, that shows that taking the aromatase inhibitors for 10 years instead of 5 years does not increase survival, but dramatically decreases the incidence of second cancers. So the prediction is by 30 years out, there'll be more patients alive. Meaning we have to look for cancer survivorship for a whole lifespan. We can't look at some arbitrarily fixed time. 5 years got there in cancer therapy because most of our therapies were inadequate, so you knew whether they worked or not in a short period of time. As the therapies get better, you have to look for a whole lifespan. Okay, prevention of patient-driven bilateral mastectomy is a craze in the United States, partially driven by genetic testing, but also driven by the patients with hormone receptor negative breast cancers having no other way to prevent second cancers besides having bilateral mastectomy. So oftentimes they may have breast conservation, but once they get a few years out and begin to think about and have a few extra biopsies, they begin to think about the possibility of having to go through the chemo again and say, I'll do anything to prevent that. Well, maybe we need to be better and less toxic with our treatments, but this is a patient and public-driven phenomenon now, whereas breast conservation was something physicians held back on in the 1980s. Now physicians find way too many women won't bilateral mastectomy and may attribute more therapeutic benefit to mastectomy than is actually there. So we struggle with how to deal with that. All right, screening. The American Cancer Society changed everything in October and November when they changed their screening guidelines. The U.S. Public Health Service Task Force had been knocking at the door of this for several years, but this was the first real cave as to screening interval things. So let's look back at breast cancers. We learn from pathology things like invasive ductal, invasive lobular, etc. But the things that are most important are the groupings that we get out of our predictive factors, because they're the ones we can affect treatment. So if you ERP are positive, HER negative, we call you luminal A, that's about 65% of breast cancers. These are the slow-growing breast cancers. They are the ones by far and away most likely to be found by mammography. Anything that's fast-growing will over 50% of the time never be seen on the mammogram. So we have a screening test that finds the most indolent cancers, and the most aggressive cancers it fails at. It's quite the opposite of what you'd want from an ideal screening test. Luminal B is ERP positive, HER2 positive. They tend to be fast-growing. Mammography tends to fail. They tend to be more resistant to drugs. HER-type, ERP or negative, HER positive, these become super sensitive when you give Herceptin with the chemo. We're doing really well with them right now. Basal or triple negative subtypes are the odd kids out. They do not respond to the classic drugs the rest of breast cancer responds to. They were really only discerned as different from regular breast cancers between 5 and 7 years ago. They have a fascinating sort of history. Most breast cancer is a disease of affluence. If you look around the world, as you become more affluent, you get more breast cancers over a lifespan. It increases with age. Nulliparity increases your risk. Basal is different. Basal is a disease of poverty. The earlier age of first pregnancy and multiple pregnancies increases the risk for basal. So just opposite the rest of breast cancer. Now, the incidence of basal, or triple negative, is very interesting. It's about 30% in the US, or slightly less. It's in the 20s in South America. It's 19% through most of Europe. It is 19% in Kenya. It's 7 to 9% in the Arabian Peninsula. It's about 6% in India. It's about 3% in East Asia. It is 88% in Nigeria. This is the breast cancer of the young African-American female in this country. What I've just given you in terms of percents of distribution is the distribution of Mus domesticus, the domestic house mouse. Mus domesticus is the primary vector of murine memory tumor virus. We've not been able to find mouse to human transmission of murine memory tumor virus, but guess what? Within triple negative breast cancers, there's a 100 kilobyte segment upstream of BRCA1 and those murine memory tumor virus, and in those cancers that has homology with murine memory tumor virus. So we have a question, is how do you get there? It's something we haven't answered yet, but this is an interesting story. Triple negatives may actually be related to some sort of vertical transmission of murine memory tumor virus or some retroviral vector carrying a segment of murine memory tumor virus into the human genome. So this is a very interesting problem we haven't solved, but it is the one that's different. It tends to the only one to really benefit from MRI screening because it has angiogenesis early on, and MRI is really looking for increased blood flow or angiogenesis. So BRCA1 families are more likely to have basal. The basal is also more likely for the young African American women. So this is the clinically detected as a rapidly growing mass in the young black woman become. All right. The American Cancer Society guidelines were published in December. They were electronically released in October. And they ask a series of complex questions as to what's our best choice for doing breast screening. Clinical breast exam, mammography, what do we do and how do we choose each of those? And guidelines were developed for strong versus qualified recommendations. And the bottom line is, self-breast exam has never been proven to prevent breast cancers in any prospective trial. So I don't think it's completely fair to say it's a bunch of male doctors blaming women for not finding a cancer sooner, but I understand where that sentiment comes from. Clinical breast exam. Every mammography screening trial we've ever done has had clinical breast exam as a component to screening for breast cancer, but we've had no data to show an absolute benefit of any particular component of the clinical breast exam. The breast exam you're likely to be taught is called a mammoprint exam, or it comes from Henry Pennypacker, who was a primary care physician in Florida, who had 780 patients he examined, 2 of which had breast cancer, and he developed models where you could feel for lumps, and that would be your way to screen for breast cancer. This was in a non-mammographically screened population. That's the last time anybody looked at clinical breast exam. So it hasn't been looked at well. So because of that, they haven't recommended clinical breast exam screening. Mammography, they changed the standards for screening and why. We'll get to that in a minute. Has to do with burden of disease and successive treatment. Remember, mammograms are screening for primarily luminal A breast cancers, which are the ones we can treat with hormones, avoid chemotherapy most of the time, and where our treatment outcomes are far better today than they would have been 10 years ago. So guess what? The effect of mammographic screening on changing outcomes for breast cancer is getting less and less every year. So that's part of this, looking at disease burden issues and saying, where does it benefit, where does it not? Over age 50, the prospective randomized trials of mammography between 50 and 70 have shown that annual screening mammogram reduces the death rate by breast cancer by 1/4. Okay, modest but real. That does mean, if you look at it the other way, 3/4 of breast cancer didn't make any difference whether you did a mammogram or not. That's the other way to look at that. Between 40 and 50, screening mammography on an annual basis does not change the death rate from breast cancer in those same patients between ages 40 and 50. However, by age 60, it cuts down the incidence of breast cancer by 1/3. Because of all those, quote, false positive biopsies that got atypical hyperplasia and ductal hyperplasia and other things, patients never got put on hormones, therefore they never progressed to the cancer at menopause. So it changes your management of the patient later that has a prevention effect, but it doesn't really prevent deaths between 40 and 50. So that's why there's such a controversy between 40 and 50. They looked for the load, the burden, and said the burden of risk is really going up between 45 and 49. The risk is still pretty low between 40 and 44. So they changed the guidelines to say up screening to 45. And 45 and 49 look pretty much like 50 and 54. And there are a lot of periclimacteric events that happen with regard to breast cancer and a flourish of breast cancer appearing then. So maybe you should screen more carefully then. As you get older, as long as you don't start on hormones, then the farther out you are from menopause, your hormonally induced breast cancers have been decreasing frequency. And remember, it's the hormonally induced breast cancer that mammograms are mostly screening for, so you can begin to back off on your screening it. So that gives them their new recommendations here, which is screen annually between 45 and 55. Between 55 and 70 or 75, go to every other year. And when you have less than 10-year life expectancy, stop screening. Now, is that normally age 75 or is that 85? Or you'll have to individualize that per patient, obviously. But when you have less than 10-year life expectancy, there's less impact of mammographic screening doing anything to improve outcome. As our treatment continues to get better for the types of breast cancer mammogram finds, this is going to be a liquid argument that's going to change it several times over the next decade. So just expect it's going to be different 3 years from now when you're out in practice than it is today. And as people live longer, when is that point where you can stop screening? Or who should you stop screening on? That's going to be dependent upon the average age of death and your life expectancy. Will we have to be better at judging that than we are now? Yeah, that probably would mean it's not going to be an age-dependent time to stop and start screening. All right. The harms, if you start women screening at age 40, 7% have a biopsy. Biennial screening, 4.8%. Start screening at age 50, 9.4 for annual, 6.4 for biennial. So screening more frequently does mean you have more false biopsies, inappropriate biopsies. Thank goodness we're not doing surgically now, but yeah, you're gonna have more false biopsies. And remember, even if you thought you got the lesion, you're gonna miss some of those biopsies. So it's not a risk-free proposition having a biopsy. Clinical breast exam. Part of the problem is we don't have much data. So, we're in the process right now of reviewing 26,882 consecutive clinical breast exams done by myself. Obviously in a high-risk clinic, since I treat breast cancer in women who are at high risk for breast cancer, so this isn't your average population in general practice. And of those, we have 712 presented with nipple discharge, 764 with breast mass, 901 with pain. Pain is not a symptom of breast cancer until you're 65 or older. Pain is not a common symptom for breast cancer. It's a common symptom for benign breast disease, but not for cancer. Mammographic abnormalities, 858. So the most common presentation is actually patients coming in with an abnormal mammogram. Second most common would be breast mass. It ends up being cancer. And third would be nipple discharge. So about 12% of patients seen with a new abnormality or complaint, or 1 in 8, have a breast cancer. So I have a standardized way of reporting my exams, and we're able to develop a scoring system very much similar to how they score radiology reports for breast cancer screening. And if you add up the score, it goes from 0 to 13. Anything with 4 or above needs to have a biopsy. It has the same probability of being positive as an abnormal mammogram. If we look here, clinical breast exam score in asymptomatic versus symptomatic individuals, there was more added benefit for detecting cancer in patients with symptoms with clinical breast exam. So there was added benefit for clinical breast exam when you were symptomatic. For asymptomatic women, it was a much smaller number. And again, because this is a high-risk population, it's unlikely that clinical breast exam in the average primary care's office, if the patient has any does not have a breast symptom or is not high risk, will have much benefit. It will have a benefit in high-risk patients where you need to drop the threshold for biopsy, and it'll have a benefit in survivors, obviously, they're by definition high risk, and it'll have a benefit in anybody who has a breast complaint. But again, the complaint of pain is less likely to be associated with breast cancer until you get older. Breast pain in an elderly postmenopausal female not on hormones above age 70 is breast cancer until proven otherwise. So it disproportionately is important when you get to the extremes of age. So sensitivity and specificity in clinical breast exam in symptomatic patients, 81 and 77%. A 10% benefit over mammography alone. Actually, half of them were best found with clinical exam and half were best found with mammogram in symptomatic individuals. So this is a bunch of hardcore statistic data there. But the bottom line is clinical breast exam, high risk and symptomatic is where you need to pay close attention. All right. Primary care role for breast cancer therapies. Since we're changing the time course, that means lots of these patients are going to be in long-term follow-up. There is the Commission on Cancer is pushing all hospitals into giving a report to the patients and the primary care physicians at the end of treatment that would catalog for you all the components of treatment that they had, so that you're able to look back if you're 7, 10, 15 years out from a cancer treatment. What did they have? What kind of breast cancer did they have? What did they have done? And how is that going to affect what's happening with them now? Both tamoxifen and aromatase inhibitors change the vagina pH and are going to give some perimenopausal vaginal dryness symptoms. If the patient's on tamoxifen, you can give topical estrogen in the vagina because tamoxifen is a competitive inhibitor of the estrogen receptor. So as long as you're only using a little bit for a short period of time, you're still going to block the effects for breast cancer. It is unsafe to give topical estrogen or progesterone to a woman on an aromatase inhibitor, because those patients have estrogen withdrawal by blockade of DHEA conversion into estradiol. And if you give them any exogenous estrogen, they're going to suck it all up, and you'll have proliferative changes and progress quickly. So, weight gain, sudden weight gain in the postmenopausal patients is associated with breast cancer. So breast cancer survivors going and suddenly gaining 15–20% body mass, you need to start looking for meds. The other thing you need to start looking is if they have shingles. Shingles often means they're immunosuppressed. They're often immunosuppressed because they've got a cancer, an occult cancer. All right. So what else can you do? The anti-HER2 drugs are associated with congestive heart failure at higher risk, as is left chest wall radiation. Smokers have a higher incidence of benign malignant lung lesions in the radiated tissue. So a smoker who has right breast conservation is going to have some of the right lung radiated. So if they were smoking when they're radiated, higher incidence of cancer there. Chemotherapy alkylating agents, secondary leukemias and lymphomas. So that's something you have to anticipate carefully. Gosh, why is this backing up on me? Anticipate carefully in your survivorship plan. Remember, this includes multiple myeloma. So multiple myeloma, leukemias, and lymphomas, they typically happen at peak incidence between 6 and 9 years out. So patients who are suddenly tired, have a few sort of juicy lymph nodes around, that's the group to worry about. Neuropathy after taxols and taxanes is very significant. It's very low wear off because it gives you neuropathy, particularly in the long nerves. Falls after breast cancer therapy are increased by 80%. So we're just now beginning to realize that the numbness that we give patients as a result of some of our chemo may dramatically affect them in ways unrelated to their breast cancer. So there'll be a lot more happening with that information. Brisk walking for more than 3 hours per week cuts recurrence by 30%. Chemotherapy cut recurrence by 30%, 33%. Brisk walking can do almost as much good as chemo for the breast cancer survivor. So there's some other therapies out there we've been hesitant to require, but that's important. Triple negative breast cancers, which tend to not respond to the drugs as well, guess what? Respond to exercise and diet measures better. So figuring out how an integrated plan for follow-up of survivors and maybe even preventing breast cancers could be very important. Today, the vast majority of breast cancer survivors, over 69%, will die of heart disease. So heart disease is our biggest issue. You're actually more likely to die of heart disease than you are of breast cancer today. So, all right, as a primary care, you watch for compliance, particularly with the hormonal drugs. Arimidex or anastrozole, Femara, letrozole, Romacin or exemestane. These are the 3 pill forms of aromatase inhibitors, they're the common ones out there. All cause small joint symptoms, hands, feet, primarily if your vitamin D3 level is less than 60. The vitamin D3 level is set for normal range, usually most labs between 30 and 100. Unless you're above 60, you're going to have significant joint pains from the aromatase inhibitors. As long as you keep it above 60, that keeps that to a minimum and decreases any effects on osteoporosis and osteopenia. It also happens to have, if you keep it above 60, a prevention effect for that excess number of colon cancers breast cancer survivors didn't have. So, all right. So, pay close attention to GI symptoms. GI issues can be binders of the pill in case they're aromatase inhibitors. But remember, because they have increased risk of colon cancer, you've got to be more careful about screening for GI things. So, New guidelines are useful in the lowest risk patients. So low risk, no family history, low gamma risk. You're perfectly fine not doing a clinical breast exam every year and sticking to the new guidelines. The old guidelines of annual mammography are important if you have a positive family history of breast or ovarian cancer, a personal history of breast cancer, any history of any proliferative pathology in the breast, and if you've had more than 2 breast biopsies in the past, all of which indicate an increased risk. So clinical breast exam is primarily for the symptomatic. So if you're in primary care, remember to keep patients on the hormonal treatment, because sometimes that was their substitute for chemotherapy. So they have to complete courses of 5 or 10 years to be effective as the chemotherapy option. D3 is important, especially in patients on their aromatase inhibitors. And patients who were treated with hormone treatments many years ago have a benefit for an aromatase inhibitor now for 5 years, both in prevention of recurrence of the original primary and prevention of second primaries. So a lot of those patients are not even coming to their doctors anymore, their oncology doctors, because they think they're done and over. So finding them and making sure that they get the right prevention drugs. The aromatase inhibitors are all now on the, at least one of the 3 aromatase inhibitors is on the cheap list at all the major pharmacy chains. So you can get it between $4 and $9 a month, so it's pretty cheap. And if it has a prevention effect of 80%, that's how it's going to be worthwhile doing that for 5 years to see that effect. So, I've covered lots of questions. Now, everybody in here, the average woman's going to have 3 breast biopsies in her lifespan. So, most of you being female, it's going to be a lot of breast biopsies. Remember, 1 out of every 8 breast biopsies is going to be a cancer. And that's a lot of breast cancers too. So this is going to be a pretty commonplace thing. So you're always going to be asked by family and friends, and somebody just got breast cancer, what do you do? And the answer is the NCCN guidelines. There are NCCN guidelines for diagnosis and screening. There are NCCN guidelines for risk reduction, that is prevention. And there are diagnosis for treatment. They're updated every 6 to 8 weeks throughout the year as new data comes in. The other NCCN guidelines are updated on an annual basis. But the breast ones, because there's so much research data coming out so quickly, are updated more frequently. There have been, the second change has happened after ASCO this week. We'll have the 3rd change probably by mid-July for these guidelines. So nccn.org is the place where you can get them. And it has lots of information. But let me point out to you, LCIS, history, physical, mammogram, biopsy, core biopsy, you can do a surgical excision. As long as you only have LCIS, then you think about risk reduction. Ductal carcinoma in situ, we do the workup, we get our prognostic and predictive factors, we do our treatment, lumpectomy with radiation or mastectomy, limited life expectancy if you look at all these footnotes here. You can do it without radiation. In post-treatment, you consider risk reduction or prevention strategies. And what is nice about this is every footnote and stuff, you can click on stuff, it'll take you to a bibliography. In the bibliography, everything's hot linked, so you can read every paper on which these decision points were made. So it's a great resource in terms of you trying to learn what's going on or what should happen, clinical staging and what we do. Now, if patients present with tumors which are bigger, are node positive and have a worse prognosis, we tend to put more chemotherapy up front, shrink the tumors down before we do the surgery. So we can be more successful with breast conservation. We can also test the drugs, make sure they really work, and if they're not working, make changes in the drug therapies. If we take all the known tumor away, we may lose our chance to find was that drug's really effective against the tumor. So that's sort of the long term. Now, this has what's called evidence blocks, and I'll go back and up here and show you that. Because we have lots of data, here's what an evidence block is: the efficacy of the regimen, the safety of the regimen, the quality of the evidence, the consistency of the evidence, and the affordability. So each one of these branch points are rated on the quality of our data to support that and how efficacious it is and whether it's financially feasible. So this is a very high standard to look at the data quality. So you can look at it without this, but if you get the evidence block thing, it'll tell you how sure we are the answer's correct. So if that's the way, you can always find out more information. Very straightforward algorithms. There are errors of commission and errors of omission in breast cancer. If you choose to do a PET scan or a blood test at the wrong time, you may burden yourself with too many false positives, then you have to biopsy things and then you hurt patients with it. So you have to make sure you do things just in time, just at the right branch point. If you do it at any other time than the clinical trials showed was optimum, you may be stirring up trouble. So it used to be that oncology was what I call, I'm a butterfly medicine. You flitted from flower to flower in no specific order, so everybody who did it a little different way. We've proven in breast cancer, you gotta do it the same way, you get a reproducible result. So we're very rigid, and that's gonna be the template, I think, for oncology care in general in the future. Extreme rigidity with when you do what test, why you do it, and how you handle an answer if you get a funny answer out of it. So extremely rigid, reproducible. Some people refer to that as cookbook medicine. We refer to it in breast cancer as evidence-based medicine. Don't do things without evidence. If you need evidence, do the clinical trial and get the evidence. Don't just do things because you think it might help. So, hardcore evidence driven. All right, now, anybody have any questions about breast cancer?
I have one question. If you do a biopsy and it comes back negative or positive, in the future, could that leave scar tissue that could get in the way of getting a correct mammogram down the road?
Anything we do, whether it's biopsy or any therapeutic thing that we do, can always give increased scarring. There is there's a change in the collagen maturation over time with scarring. So you can expect after any biopsy that you'll have redness in the scar, shortening of the scar. The scar will be hardest and shortest at about 12 to 16 weeks. And then take about 6 to 9 months to soften up. So anytime you biopsy something, your first screening mammogram is at 6 months. Because you want to make sure that you didn't miss. You're not in that 1 in 50 that you missed something. And by then, most scar is clear enough you can see through on the mammogram well enough to tell what's happening and what's not happening. Radiation will make the scar persist for longer. Chemotherapy may change the rate of scar maturation. So if you have a lumpectomy and radiation and somebody got chemo, they may have a scar around the lumpectomy that's persistent for 2 or 3 years that may limit mammographic screening. But under normal circumstances, within a month or 2 of the skin scar bleaching from red to clear, things should look pretty good on the imaging. That help? When we talk about biopsy, you'll see the words on reports, concordance and discordance. So the radiologist, if they are going to biopsy something, is required to list a list of pathologic findings that would be appropriate for that biopsy. And the pathologist is blinded to that, so they do the reading. And if the pathologist's findings do not add up to one of the diagnoses the radiologist found acceptable for the image abnormality, It's called discordant. Every discordant core biopsy comes to open surgical excision. If it's concordant, then you see the patient back in 6 months, repeat the mammogram, make sure nothing else is happening, and then put them back on an annual schedule. So concordant and discordant is what that's about. Nobody has family members who have breast cancer have a burning question? Always get that from medical students. And so-and-so has less than so. There are many similarities between breast and prostate. Prostate, the peak incidence is a little later. It's more than a decade later, so the average for breast cancer in the U.S. is about 58. It's 68 to early 70s for prostate cancer. Let's see, both have something funny happens at the pubertal growth spurt. So the laboratory data suggests that the pubertal growth spurt may be very important in initiation events for both breast and prostate. And then the rest of life is a series of acceleration and deceleration events that get you there. If you live long enough, you're going to get them. We know every man ever autopsied over age 80 has microscopic prostate cancer. That's a little bit easier because the prostate gland is small, relatively small. It's a little better preserved at autopsy. There's more autolysis in the breast. But as best we can tell, between 105 and 110, every woman with a breast cancer. So the curve smashed out a little bit more in breast, a little bit more peaked up in men, but the hormonally induced breast cancers have a lot in common with each other. And we have had better hormonal therapies for prostate for a long time. So prostate does not have as much of this, the equivalent of triple negative breast cancer in breast. That may be a funny, maybe even viral induced form of breast cancer. If it is, theoretically, we immunize people against mouse memory tumor virus. So it might be the Gardasil of breast cancer. But lots of research to be done on that particular area. Thank you very much.
Thank you.